طيب دكتور هلا احنا كده لايف على الفيسبوك وعلى اليوتيوب كمان.
Okay. Let's go back one. We're here.
Dr. Helen, we should start now.
Okay.
Yeah.
Good.
Okay. Well, here in California, it is early morning, so I will say good morning and welcome. If you have come for the transposition surgeries in strabismus, you are at the right place. It is Sunday all across the world, and we are here to discuss what happens when you have to move muscles along the eye. This is a joint webinar between the Egyptian Association of Paediatric Ophthalmology and Strabismus and the World Society of Paediatric Ophthalmology and Strabismus. We will have fun today, and you really don't want to hear me talk too much saying introduction. So I'd like to get us right to our panelists and to start hearing some important information. So we have two discussants with us today who have kindly offered to be the ones asking probing questions and insightful comments. And the first, and we're expecting a lot from you, is going to be Ed Buckley. Ed is the Vice Dean of Education at Duke, where he is also the Director of the Pediatric Ophthalmology Fellowship Program. He's the past president of APOS. Pretty much within our field and within ophthalmology, Ed Buckley has done it all. And he's one of the people who I always stop and listen to whenever he speaks. So we're thrilled that Ed is going to be here giving us all his comments and his experience. We also have Daniel Salko. Daniel is fabulous because he is an international doctor in and of himself. After going to school in Germany and Austria, and you know, I can only speak a little bit. Ich habe für 2 Jahre Deutsch studiert, Daniel, and so that's my whole German. But he also trained in the United States and was a professor at my alma mater, Yale, before moving back to Germany. So Daniel is going to bring a wealth of international experience with viewpoints that are different from around the world. Daniel, I'll share with you that when I grew up in ophthalmology, everyone always said to me that if you think you've done it first, check the German literature. So we're going to make sure that you have the insights to help us with recognizing what has come before, what we know about what's come before, and asking terrific and fabulous pointed questions. No pressure. And then next, I'm going to introduce my co-moderator, Khala El Hilali from Egypt, whose name I am praying that I got right, that I said it correctly. She's the vice president of the Egyptian Association and director of pediatric ophthalmology and strabismus at the Children's Hospital in Cairo, and is an avid bicycle rider, I think. Khala, is that right? So, and has done a huge amount of effort putting this together and picking fabulous speakers and in all the work to make this all happen. So everything that happens that is good, we know who to give the credit to. If it doesn't go well, it's my fault. Khala, I'll turn it over to you now.
Thank you, David. Actually, I would like to start by expressing on behalf of the EPOS our great appreciation to yourself, to Ramesh Kakunya and Ahmed Awadin for bringing this symposium, this webinar and organizing this webinar and bringing such a wonderful group of people together. So thank you, David. I will start by introducing you, even though you don't need an introduction. It's a wonderful picture of your family here, and I'm sure that you are going to enjoy the rest of your day celebrating Father's Day with them today. I want to wish everybody happy Father's Day in North America as well. So David is the Ann Ratner Professor of Ophthalmology and Pediatrics. He's the director of the Ratner's Children's Eye Center at Shiley Eye Institute, University of California, San Diego. He's also the co-executive director of WSPOS and a great dad. I'd also like to, I'm very happy to introduce also, to have with us here Linda Daggy, Assistant Professor of Ophthalmology, Harvard Medical School. She's the Director of Adult Strabismus at Boston Children's Hospital. She's an ophthalmic consultant for the Craniofacial Division. She was also director of APOS Adult Strabismus Task Force, which created the AAO preferred practice patterns for adult strabismus. And she's also a member of the Squint Club. We're very fortunate also to have Amr Kamtoushi from Egypt. Professionally, Amr is a scuba diver who spends most of his time with sharks underwater, but when his head is above water, he's an assistant professor of ophthalmology at the University of Alexandria. He's a board member and founding member of EPOS, and always comes up with very fresh and bright ideas for us. He's the chief consultant of pediatric ophthalmology and strabismus at the Eye Care Hospital in Alexandria. And I would also like to welcome Ramesh Kakunia from India, who's the head of the Child Sight Institute and LV Prasad Eye Institute in Hyderabad, India. He's the executive committee member of WSPOS with special interests in complex strabismus, pediatric cataract, pediatric neuro-ophthalmology. And also my colleague, Ahmed Mustafa Kamel from Egypt, professor of ophthalmology, Cairo University. He's currently an ophthalmology consultant in Saudi Arabia, and we sorely miss his input at the pediatric ophthalmology unit in Cairo University with special interests in teaching strabismus, pediatric cataract, and glaucoma. We're very fortunate to have Craig McEwen from the US, professor of clinical ophthalmology, Bascom Palmer Eye Institute, University of Miami, Miller School of Medicine. It's a great picture of himself with Ian, his friend, and his son and his best friend. We're very fortunate to have him with us in Egypt last year. He attended our meeting and his input was very much appreciated. And last but not least, we have Ahmed Awadin from Egypt. And besides everything that's written about him on the slide, interestingly, Ahmed finished high school when he was 14 years old, completed medical school when he was 20, and is actually the youngest person to become full professor in ophthalmology in Cairo University. He's a great multitasker, organizer, and very important and instrumental in all our scientific activities at the Pediatric Ophthalmology Department and the Department of Ophthalmology as a whole. I will end my introductions here, and Ahmed will now start the poll question, the first poll question before we move to the first speaker. And I'll stop sharing my screen. Ahmed, go ahead. Ahmed, can you unmute?
It should be launched now.
Okay. So the first pulse question is for 6 nerve palsy with 40 prism diopters, esotropia in primary position, and -4 abduction deficit. And my preferred transposition procedure, in addition to recession of the medial rectus if needed, is a Hammersheim, first option. The second option is superior rectus transposition to the lateral rectus. Third option, full tendon superior rectus and inferior rectus transposition to the lateral rectus. Fourth option, Jensen procedure. Fifth, Nishida, modified Nishida procedure, or others. And how much time do we give the, oh, very quick. And so we have the poll, and it looks like Hammersheim and Jensen are tying here. Okay, so now we can, without further ado, move to our first presentation. And please, Linda, would you please share your screen? And Linda will talk about transposition procedures for abduction deficits. Linda Daggy, thank you.
Unmute.
Hi, do you have the full screen?
Yeah, we do.
Great, great. So thanks for the opportunity to speak. So we're going to talk about transposition procedures for 6 nerve palsy and Duane's esotropia. I'm not sure why this is not advancing. Okay, so first of all, these are just variations on a theme. A 6 nerve palsy, of course, has absent or incomplete innervation of the lateral rectus with secondary increased medial rectus tone, most typically. And Duane syndrome, esotropic variants making up 85%, has absent or incomplete innervation of the lateral rectus as well, but with aberrant innervation of branches of the 3rd nerve. So first, let's take a moment to talk about alternatives to transposition, because transposition isn't always the right answer. Some providers recess the medial rectus alone, but this results in a reduced binocular field of single vision. It is a worthy option if you have a very small compensatory head posture, maybe less than 10 degrees, and an abduction deficit of maybe -2. Not really the subject of our talk today. Medial rectus recession and lateral rectus resection is certainly an excellent option for a partial 6-nerve palsy. There's no complications there with vertical misalignment or torsion. It's generally avoided in Duane's esotropia because of the possibility of worsening globe retraction with resection of the lateral. There are some exceptions, however, which I have not chosen to do, but with very mild retraction and no upshoots and downshoots, Steve Kraft, Yair Morad, and Jim Mims have particularly been interested in doing recess resect for some of those patients. And I have it known that Steve Kraft is about to publish a larger series using this as an option for certain cases in select series. So transposition procedures, types. There's transposition of both inferior rectus and superior rectus to the lateral. That's considered a full vertical rectus transposition procedure. It can be full or partial tendon transposition with or without vertical rectus muscle disinsertion, with or without augmentation of the transposition. And the augmentation can be with or without adjustment. There are traditional methods and adjustable graded methods. And if you look at this photo adapted from Doyle and Hunter's recent JPOS publication, you get sort of a bird's eye view of what your options are. You have this traditional full tendon transposition along the spiral of Toulouse, here shown with augmentation, doesn't have to be. You have the more recently introduced crossed swords type of transposition that transposes the superior, the inferior, but this is done with adjustable sutures, where the adjustable sutures are passed under the lateral rectus to the opposite pole. There's just a few reported cases using this technique. You have here a series of partial vertical rectus transposition procedures, this adapted from Brooks, where the muscle is split in half, and half or a third of the muscle is transposed to the lateral. Here, the classic Jensen, where the muscle, the superior and inferior are split. The lateral is also split. There's attachment to the lateral rectus. Some have criticized this because it may weaken lateral rectus tone by splitting the lateral rectus. You have Nishida's more recent interesting innovation of splitting just the superior and inferior, attaching these split halves, and these are split about 15 millimeters down, attaching them about 8 millimeters back to the area adjacent to the lateral rectus, not affecting lateral rectus function. This has been published only in 6-nerve palsy. And you have Hendler's version where he cuts the superior and inferior rectus muscle about 3.5 millimeters back and sort of slides the posterior piece of that along the spiral of Toulouse, making a different modification of this kind of full tendon transposition. They're all variations of a theme. These, of course, can be done with augmentation, shown in some of the slides we have just seen. And another form of augmentation comes in the form of resection. There's no dose response curve for any of these. Any of these may induce vertical or torsional disturbance by the placement of these muscles. Kraft has suggested resecting the superior rectus and then recessing it a little. In his version of it, he feels that if you advance the resected superior as much as the resected inferior, you'll end up with a hypertropia. So he recesses the superior 2 millimeters, but otherwise places them, note, not along the spiral of Toulouse, but perpendicular to the muscle, to the lateral rectus. So there's really a host of different options to consider. What are the benefits of vertical rectus transposition, superior plus inferior? Well, we know that vertical rectus muscle transposition improves the field of single binocular vision about twice as much as medial rectus recession, and that's quite important for most patients who need to drive and perform other activities. If there's significant medial rectus contracture, however, you're going to need to do something to reduce the medial rectus tone, which would involve a second procedure, either by recession, which increases your risk of anterior segment ischemia, or by the use of Botox. Some have advocated a simultaneous lateral rectus plication. This really gets you into the realm of 4-muscle surgery, really increasing the risk of anterior segment ischemia and possibly worsening lobe retraction if you're considering treating Duane syndrome. So what are the drawbacks to vertical rectus transposition? First of all, I think the major drawback is it's pretty messy. It's very difficult to reverse. You have scarring all along the lateral aspect of the globe. And even techniques designed to reduce the risk of anterior segment ischemia provide no guarantee, because also more conjunctiva is dissected, and conjunctival dissection increases the risk of anterior segment ischemia. There's also the risk of induced vertical or torsional diplopia. Most larger series have shown that the risk is between 3 and 10%, some studies even higher. So doing a balanced vertical rectus transposition, surprisingly, is not the perfect option to reduce the risk of some kind of induced vertical or torsional problem. And then again, you need to address the risk of reducing medial rectus tone. And there you're involving 3 or possibly 4 muscles. So in Boston, we generally do the alternative, which is superior rectus transposition. It's typically done with simultaneous medial rectus recession. You can augment the transposition. And so both the medial rectus recession and the augmentation can also be adjustable. And what have we learned doing superior rectus transposition? First of all, it's extremely vessel sparing. You're really only operating on the superior rectus and the medial. You can do it alone for deviations of under 15 prism diopters without the medial rectus. With medial rectus recession up to 5 millimeters, you can fix up to about 50 prism diopters. And with bilateral medial rectus recession at the same time, you can fix more than 50 prism diopters. Or you can use augmentation for greater effect. What about superior rectus transposition compared to medial rectus alone? There's less reduction in adduction for the same reduction in esotropia if you do superior rectus transposition, and more improvement in abduction with less recurrence of esotropia. What about superior rectus transposition versus vertical rectus transposition? Well, both, interestingly enough, have a comparable risk of inducing new vertical or torsional diplopia. Superior rectus transposition plus medial rectus recession, which is a 2-muscle procedure, gives equal reduction in esotropia and greater improvement in abduction than vertical rectus transposition alone if medial rectus recession is not done at the same time. But the big question always is the issue of whether there's a greater risk of induced vertical or torsional diplopia when you have an imbalanced transposition. We have impressed now a very large series, 69 patients, half with Duane syndrome and half with 6th nerve palsy, who were treated with superior rectus transposition plus medial rectus recession with augmentation. We found an incidence of 7% of symptomatic induced vertical diplopia, successfully treated in all but 1 patient. And this is really comparable to the 3 to 10% seen after vertical rectus transposition. And it's a very large series, largest to date. Interestingly enough, the shift was in the hypotropic as well as the hypertropic direction, though there's a propensity towards hypotropia. Now, how can it go both ways? Well, if you think about it, you're advancing the superior rectus when you're transposing it along the spiral of Tillot. So you can actually cause increased hypertropic tone. On the other hand, you are shifting it laterally, reducing its function as an elevator. You have to be very careful to separate the superior rectus from the underlying superior oblique along the frenulum to make sure you don't cause an inadvertent transposition, if you will, or Hirata Ito effect, causing hypotropia. The procedure tends to produce intorsion rather than extorsion, although it has not been symptomatic in the vast majority of patients seen. So we'd like you to consider the possibility of superior rectus transposition with adjustable medial rectus recession and possibly even adjustable augmentation, because you can adjust the horizontal and vertical component as well as any possible torsional impact of the procedure. And you have a really minimized risk of anterior segment ischemia, and you can take care of the entire problem with 1 trip to the OR. So I want to introduce you to something that's new, still impressed, which our current fellow helped me with, Dr. El Husseini. This is adjustable graded augmentation. And here's one image of it. Here's your superior rectus transposed along the spiral of Tillot. Here's the lateral rectus. And what I like to do for larger deviations, certainly not for small ones, is to place 3 adjustable sutures, augmentation sutures, one typically at 6, 8, and 10 millimeters back. It's shown here done with Vicryl. I've done it with Vicryl and with Mersaline. And we check for any possible induced torsion after we tie each one. So I'm going to show you quickly a video of this procedure. You first mark the cornea at 6 and 12 o'clock. Here we are separating the superior rectus, separating from the frenulum. And we mark the lateral rectus at 6, 8, and 10 millimeters back. Likewise, the superior rectus. And in this particular patient, done with Mersaline, you'll see me place 3 possible augmentation sutures. In Boston, we like to call this also 3-button technique. You can do this with 2 augmentation sutures. There's no rule that says you need 3, and you can choose different distances. But what I like to do is I tie the first augmentation suture, check for any induced torsional change in the eye. Was minimal there. Second, check for induced mechanical torsional change. Third, check for any induced mechanical torsion. And then I compare this to the torsion preoperatively. Here for exocyclotorsion, here we see net 5 incyclotorsion. I know this patient will tolerate all 3 sutures placed because you can tolerate up to about 7 degrees of in or ex cyclotorsion. If I had found that this patient had too much induced intorsion, I would have popped the ultimate augmentation suture. So you can do this in a sort of adjustable way. I think we can close this film. If you want to be sure that you haven't induced any excessive torsion, you can pop any of these augmentation sutures both in the operating room or in the recovery room when you're doing any medial rectus adjustment. The last thought is inferior rectus transposition. This has a special role in certain cases, certainly if you have significant preoperative incyclotorsion and you're worried that a superior rectus transposition might cause too much incyclotorsion. And it also has been used to augment the impact of SRTs in some cases with really maximum preoperative esotropia in the 80 to 100 prism diopter range in cases of 6th nerve palsy. Thank you.
Thank you, Linda. And we would like to ask our discussants, Dr. Edward Buckley, would you like to weigh in with your comments?
Well, yeah, and Linda's just given a 4-hour summary of
Dr. Buckley?
procedures in 5 minutes, so I'm not quite sure how I'm going to discuss all of this, but clearly, she's a strong proponent for the superior rectus transposition, single muscle transposition for this particular situation. And I must confess, for quite some time, I was very skeptical because of the concept of moving just one vertical muscle over. Had to create some torsion somewhere along the way because we use it to treat torsion. And so the question is, why wasn't that happening? And I don't have a good explanation for that. It should, but it doesn't, and it does work. There's no doubt about it. So if you are trying to take care of a relatively moderate size deficit, one muscle over combined with the medial rectus recession does work. What we didn't talk about, and so I'll emphasize that, is that we didn't mention anything about the contralateral medial rectus. And the contralateral medial rectus has a significant role in transposition procedures for ETs. And it has 2 functions. One is that it matches the abduction deficit on the other side, which helps expand the window and center the window of single binocular vision. And the second is that through Sherrington's law, it gives you maximum inhibition of the medial rectus on the paralytic side, which allows the spring effect from the transposition, whatever transposition you're using, to be maximal. And so I would argue that you'll get a little bigger and a little wider field of single binocular vision if you do the contralateral medial rectus. But my surgery of choice is now either the superior rectus or vertical rectus. Both come over. I think bringing both over gives you just a little wider range of single binocular vision. There's not been a lot of studies comparing the 2. It is, I don't think it's any more complicated than what we just saw. I've not done more than 1 suture for a augmentation, so I'll be very interested to see the paper when it comes out and to see how that potentially has changed things. It does make some sense to have more than 1 suture holding that superior rectus over. All of us had the experience of thinking that we did an augmentation or somebody did an augmentation. We went back and found the muscle not augmented at all. It was right back where it came from. So sometimes they work their way through. I noticed in the poll initially that Jensen's and Hommenschein's were the 2 most popular. I've not been a big fan of Jensen at all. And that's because if you think you got to mess with vertical muscle transposition, try splitting all the muscles and looping them all around and try undoing that one. I spent first part of my career undoing a lot of Jensen's that didn't work. So I don't go there. Hubelstein works somewhat for those who have vessel sparing issues going on, and Craig's going to talk a little bit about that in the past. So nice job presenting a very complicated topic in a very short period of time.
Thanks.
Thank you. And Daniel, would you like to weigh in with your comments?
Yes, thank you. I thought it was a fantastic presentation. I think when we do these procedures, there are very few who have a large number of cases. I mean, I have a good number of surgical cases, but then again, I don't have enough cases that I could really look at all these different procedures and get comfortable with the Jensen in certain cases, with the full muscle transposition for others, the super rectus, the Boston procedures, I want to call it, for yet others. So I think it is important to have maybe 1, 2, or 3 options, get comfortable with them, and kind of know what you can expect from them. I have originally been taught the full tendon, the full muscle transposition, and then you find yourself a little bit in a situation where you can't really, or it's hard to operate on a third muscle, as Ed just said, on the same eye. So I have switched primarily to the Hummelsheim plus recession of the medial rectus. That gives you, in my experience, a good pull, a nice pull laterally, temporally, and you have to oftentimes really release that restriction. Unless this 6-nerve palsy is pretty new, you'll have a really contractured medial rectus, and I find you need to somehow loosen that tension. You need to loosen the medial rectus, and I like to do that by a simultaneous medial rectus recession. You can do that on a adjustable suture if you like. I would like to agree with Ed, as he said, if you split muscles, sometimes it works really well, but sometimes it is quite a bit of bleeding and you have a long edge, so a lot of potential for scarring and fibrosis, and I like to avoid that. The last thing that I want to say is, if Linda says she hasn't had any symptomatic torsion after suprarectus recession, I of course believe her. But looking at these marks, one mark must be at least 5 or 6 or 7 degrees in width. So I wonder how accurate you are actually, or you can be measuring that intraoperatively. That's just something that's a little hard for me to imagine.
Oh. Can you hear me? Yeah, great. That's an excellent point. Let me share two thoughts about that. The first thing is, if you're going to do this adjustable augmentation with multiple sutures, or even with just one suture, the first thing to appreciate is you mark the cornea once the patient is anesthetized. I do these under anesthesia, and lying down, because what you're looking for is a net mechanical torsional change. This is purely mechanical, induced by the transposition. It is not a neurologically changing one. And what you're doing is you're looking for a change with, first of all, when you take off the superior rectus, you can see a small change just by disinserting one muscle, and with each augmentation suture that you add. Yes, you're right, it's imperfect. It's imperfect as strabismus surgery is imperfect. I would say that most of the time we're looking to make sure there isn't some large, big surprise induced torsion. And I should add that in this study where we looked at 69 patients, I was not the surgeon in all of them. This is a big practice here in Boston. I was in some of them. And when we stated that there was no permanent induced torsional change in 1 or 2 patients, it's because they had this kind of adjustable augmentation, so that an augmentation suture could be popped, removed, and any kind of induced torsion resolved that day then. One advantage of multiple augmentation sutures is you don't have to lose all the augmentation if you have a torsional problem. So just say you put one at 4 millimeters and one at 8 millimeters, and you had some induced torsion, you could pop the 8 millimeter one in the recovery room or in the OR. And if the patient doesn't have a torsional problem, you at least have some augmentation effect. You haven't, it's not an all or none phenomenon. There is a form of adjustable augmentation with a sliding noose, but I think that this is probably more secure over time because you have these multiple sutures in place.
Linda, just one comment is that in 2015, our group published another technique that just wanted to mention, and it was
Yep.
this was done with Rich Hurdle and Mickey Kenori from Israel and Mahmoud El-San from Alexandria, where we did a Hamelsheim with augmentation, the posterior fixation, but we also did small plications so that we could address the medial rectus if need be. And we did iris angiograms and demonstrated maintenance of blood flow, which Craig is going to talk more about later. But it was a way to leave blood flow for the anterior segment from both the superior and inferior by doing the half tendon shift, but also get the larger effect by doing a plication, which also can maintain the anterior segment blood flow. And we got large range of binocular vision when we did it. So there are other techniques. We don't always use that, but in somebody who we think that there might be an issue down the line with anterior segment ischemia, as Craig will talk about, we're trying to maintain our anterior ciliary vessels.
Great. I saw that one as well. There's just a host of probably 50 possible alternatives, which is great. We have a lot of choices. And as is true for all of us, none of us who do a lot of this sort of surgery use the same technique for every patient. You know, I don't do every sixth nerve and every Duane's with this SRT. You know, it's a patient by patient choice based on all the factors we have to consider.
And Linda, I wanted to ask you this question in specific because you've written about this.
Yeah.
How do you judge a success?
So my first criteria is just the patient walk in with a smile. Okay. I think that's true for all of us clinicians. It sounds very hokey, but you know, if they're happy, I'm happy. If they're unhappy, even if I have what looks like on paper the perfect result, I've got a problem on my hands. Mm-hmm. So the first thing is the patient happy? I think if, you know, I think it would be great to do a future study, which I haven't done, where we really measure true binocular fields pre and post-op. But I judge their ability to drive, parallel park, function moderately in sports, tennis, other things. If they feel pretty comfortable leading a pretty full life, that to me is a great success.
See, I wanted you to say that because none of that is the exact measurement.
Yeah, none of it's the exact measurement. And the other thing, one other important thing to me, which I don't think we talk about a lot, and someday one of us should write about, is the importance of maintaining convergence. You know, I think we get a little obsessed with compensatory head posture, but a patient who ends up with zero compensatory head posture at distance and near, but has had too much transposition, too much medial rectus recession, cannot converge, has a big problem. You need to converge to read. Even in social interactions, as someone comes closer to your face, you expect to see that convergence. Otherwise, they look like a deer in the headlights. So I think we have to moderate this goal of extinguishing a compensatory head posture, or balance that with the importance of maintaining good convergence, which is, Ed, your discussion about the contralateral medial rectus. It's something I do a lot. If you can do less on the ipsilateral, if you don't have a tight medial on the ipsilateral side, going to the contralateral does help augment the use of the ipsilateral lateral rectus and helps you reduce any need or the magnitude of medial rectus recession.
Right.
I think I've told you anything I can think of.
So we have a new poll here. And let's see how that goes. Is for third nerve palsy with a 40 present diopters of exotropia, -4 limitation of adduction, elevation, and depression. What is the surgery of choice? Ahmed, can you bring up the result of the poll? Okay, nasal transposition of the split lateral rectus muscle seems to be one of the popular options. Now, I will go ahead and start my talk. I will share my screen now. So keeping it simple, we'll talk about rectus muscle transpositions for adduction deficits. When you have a large exotropia patient with no adduction, you might think of two options. It's either a third nerve palsy, and it's not only the medial rectus that's paralyzed, it's also the other recti, or it's a lost or torn medial rectus, whether due to surgery or some other traumatic cause. Let's look at patients. Look at these two patients. They both have a left relatively large exotropia. Both of them have full abduction, and both of them have limited adduction. However, there's a major difference when assessing these patients. The one on the top, she has limited elevation. The one on the bottom have good elevation and depression, but the one on the top has limited elevation and limited depression. So we can easily diagnose the one on the top is a third nerve palsy. The one on the bottom is an iatrogenic lost medial rectus. When deciding what to do for these patients, the one on the bottom, we have a lost medial rectus, but we have a good function of the superior and inferior recti. So what we can do is transpose them towards the medial side. Of the one on the top, we only have a lateral rectus that has a good function. So we do a split this lateral rectus and transpose it to the other side. Now we take a closer look at this patient. This is his CT. We attempted to retrieve this medial rectus. As you can see from the CT, it's lost way back in the orbit. We couldn't actually retrieve that one. So we went ahead and did a transposition. However, when you do a transposition towards the medial side, there is a difference here. What Dr. Daghi talked about is transposition towards the lateral side. When you do that, as we can see, we stretch the superior or the inferior recti, and that's what you get good results. But if you do the same thing towards the medial side, you have less stretch. The muscles would be less stretched. So if you do the same thing, you would end up with an undercorrection. That's why when you do a vertical muscle transposition towards the medial side, you have to modify that a little. So the modifications would be, transposition should be combined with a resection or some form of strengthening of the transposed muscles and a posteriorly placed augmentation sutures. Show you this animation. This is what we do in a transposition on lateral rectus. That's what we do. But if you have a medial rectus that's lost, what you have to do first is to cut parts of the superior and the inferior recti, dissect some parts of them before you're doing the transposition, advance it forward, and then do your augmentation sutures and try to go back at least 8 to 10 millimeters. I think this technique would give results in adduction deficits. This is the patient, preoperative, and that's his picture. Postoperative, after resecting 6 millimeters of superior and inferior recti and transposition and augmentation sutures at 8 millimeters. Now we go to a third nerve palsy case. This patient is a bilateral third nerve palsy, traumatic after a road traffic accident. It's almost like 1 year after the trauma. And in the splitting the lateral rectus, what we do is we split it into halves and go all the way back, as far back as possible. As you can see in this picture, we actually try to split both sides of the lateral rectus as far back as we can and pull them apart. Of course, after doing good dissection all around the globe. Here we can see that we suture the upper half, cut it off, make sure that it's freely moving up and down. We do the same thing with the lower half, make sure it's freely moving up and down. And this free mobility, you get it only if you dissect before starting your sutures, dissecting all around. Then we take this is the lower half, we're passing it under the inferior oblique muscle. If you do a good dissection, it can actually show up behind under the inferior oblique. Here you can see the inferior oblique and the lower half of the lateral rectus coming up. And this is moving the muscle under the inferior rectus. You do that on the superior side as well. And this is the upper half of the lateral rectus and the lower halves. They're coming on the medial side. First time when I did this procedure, I thought it was going to be difficult to move the muscle all around, but with good dissection, it can actually come up on the other side. And here we can see when we pull the muscle to take the sutures, you can see the ends of the lateral rectus coming up to the medial rectus. And we do not do augmentation sutures with this one. I think it's too much strengthening if you do the augmentation sutures, and we end up with an overcorrection. This is how it looks like at the end of the procedure. We have the medial rectus and both ends of the lateral rectus there. This is 6 weeks post-op patients, a picture of the patient. They're doing fine. Of course, we don't expect any motility there. The eyes will be fixed in primary position. I'd like to end with a few surgical tips about this split lateral rectus transposition. First, good dissection, good dissection, good dissection. We start this procedure by hooking all the recti, dissecting 4 quadrants, making sure that the obliques and the recti are all dissected properly so that the muscle can move around. We have to split the lateral rectus as far back as possible. 10 millimeters are not enough. You should go back at least 15 millimeters of splitting. Second, When we started doing the procedure, we used to pass the muscle under the inferior oblique and superior oblique. And it's been written in literature, and we do that for some time, that we do inferior oblique myectomy and superior oblique tenotomy rather than trying to pass the muscle under these obliques. This makes it easier, because sometimes if you miss a fiber of these obliques and you try to move half of the lateral rectus to one of the sides, you may get stuck. And it's very difficult to clear it after you started moving your muscles around. Second, I'd like to warn of doing it in cases with previously recessed lateral rectus. Sometimes you get a case of third nerve palsy that had a previous R&R or even a lateral rectus recession. If you attempt to do a transposition, it can be very difficult. The muscle can be very tight. In order to move it around the globe, you have to have a very lax muscle, normal muscle. So my advice would be, try to do it if you have a previously recessed lateral rectus, but be prepared to abandon the procedure. If it's very tight, don't do it. You may end up with a serious retinal detachment. You may end up with an undercorrection, with an overcorrection that's very difficult to repair. And last, of course, the papers published about doing it in adjustable. If you can do it in adjustable, do it. This is one of the surgeries that's very difficult to modify once you've done it. If you end up with an overcorrection, hypertropia or hypotropia, I think if you go again and try to move the transposed muscles around, nothing's going to change much. So that's one thing that you want to get it right on the first time. So if you can do it adjustable, do it. However, there's a lot of dissection in this procedure. It's a very messy procedure, even more messy than the regular transposition. So it's kind of difficult to do the adjustment in the post-op, but if you can do it, do it. That's all about it. Thank you. Now to the discussants. Dr. Helen, if you can unmute Dr. Buckley.
Yeah, okay. Very interesting talk. I think I've heard you talk about this before. Certainly it wasn't you, it was someone else. But the problem I have with this procedure is not that it can't be done and not that it won't hold the eye somewhat in the middle. It's just that you take the only working muscle you have and make it not work. And so what you really end up doing is freezing the eye in a position. And hopefully you freeze the eye in the straight ahead position because it really isn't going to move any. In fact, if anything, it's going to have a paradoxical movement because you've moved the AB ducting muscle to an AD ducting position. And so when the brain says fire the lateral, the medial effort is going to occur. So I, in truth and advertising, I've not done this procedure because of that concern. I think you can get the exact same result by a very large medial rectus resection and a large lateral rectus recession, which is much less complicated to achieve. And you can pull the eye over. It will move a little bit because even with a very large lateral rectus recession, you still get a little movement of the eye. It's very difficult to cripple the lateral unless you sew it to the wall or extirpate it, which is how I kind of approach these situations. But and the other thing is if it doesn't quite work, and I'd be interested in your comments on this, if it doesn't work, so let's say you start out with a 90 of XT, now you got it down to 20. What's your plan B? The patient says, well, I know the eye's still out, it doesn't move very good. And, now what are you going to do? Because you've really got a fairly significant mess going on with the lateral over to the medial, the tunneling underneath the superior and inferior rectus, the obliques are operated on, etc. I'm not sure I'd want to go back on that one, but have you had the opportunity to go back, or is this a one and done type situation?
Well, first, an R&R will definitely give the result, but for how long will that last? I don't think 5 or 10 years down the line, an R&R will still keep an eye straight in the primary position. However, this surgery has the advantage of lasting longer, but it has the disadvantage of, as you said, it's very difficult to go back there. Dr. Awadin would probably discuss more how to handle over and under corrections. But my advice would be, if you want to go back on such a procedure, you should go back pretty early. Early as in 1 week, maybe less than that. I know that's uncommon on Strabismus practice that we go back that early. But when I tried to go back on these eyes after 2 to 3 months, as we usually do, I was very disappointed. The globe gets frozen, as you said. So if my advice would be, yes, we can manage overcorrections and undercorrections, hypos and hypers, but only if we go back into the eye within the first week. And it will be even more messy to go back that early. But I mean, there's an advantage and disadvantage to everything. You're right about it.
Daniel, your thoughts, Daniel?
Yes, I had the same. I actually would like to ask Ed Buckley how long this supramaximal recessed resect procedure works.
Well, you know, I've got some long-term, really good results with it. The deal is most people don't do enough.
Yeah, what is enough?
Enough is 10 millimeters or more. You know, if you do 5 or 6 or 7, then you're going to go back eventually. But the good news is, and I've learned that lesson along the way. That's why I got the white hair. The good news is you can go back. I mean, it isn't a hard re-op. It's a medial rectus resection, and you're going back in on. You can always resect some more, and so you can do that. But you know, if you do what you want at the end of the day is you want an ET and limited abduction when you're doing your surgery. If you can move the eye easily past the midline, you haven't done enough resection.
Well, Ed, so Ed, you raised a question that I think is an existential one for our conversation today. It's up there with what is success, but you talked about the fact that we're moving muscles that have cranial nerves that would theoretically make them do something else entirely. And yet, for example, we sometimes move a superior and an inferior, or half of it, where half the muscle is supposed to still make the eye go up and down. Are we counting on the cranial nerves at all in this situation? Or are we just creating a spring bias that leaves the eye in one direction?
Yeah, you're not, it's always been my feeling that you're not using the innervation to move the eye. What you're using is a mechanical force. And the reason that it works is, and you have to have innervated muscles for it to work, is that the muscle tissue has to stay vibrant. So if you try to move a dead muscle over, it really doesn't you don't get the spring effect that you would when you move a live muscle. But if you think you're going to get abduction out of a vertical muscle, that's not happening. I mean, the brain's not wired up that way. We're going to hear a talk in a minute or two about moving the superior oblique. And again, we'll talk about that when we get there, but that's another concept where you're thinking you're going to innervate something that's really not. My hope it has been, and nobody's come up with it yet, is that we could come up with a material which has the same kind of force muscle elasticity that we could superimpose on top of a muscle and do away with all these transposition procedures. Basically replace the dead muscle with this material that has enough elasticity that the opposing muscle can work against. And that's what we're really doing. We're giving the medial rectus something to work against when we do a transposition of anything laterally or superiorly or inferiorly or wherever we move it's the opposing muscle that's doing the job in essence.
Just to add to what you said, I mean, we never saw any abduction after moving the lateral rectus to the medial. We never saw any abduction movement on attempted abduction or adduction. The globe just gets frozen and the cranial nerves, they just don't work anymore.
So two of our panelists would like to share their thoughts. So Linda, would you please go ahead, and then Dr. Craig McEwen also wants to share his thoughts.
As many of you know, we did this sort of big red cap survey, which we're working on publishing now, looking at outcomes around the world from nasal transposition of the lateral rectus muscle for third nerve palsy. So two outcomes I'd like to share. The first is not only is it good to do a simultaneous superior oblique tenotomy, as has been discussed with this talk, because it makes it easier, it also gives you more correction. You know, the superior oblique is an abductor. And so if you have a very large preoperative angle, it actually helps you reduce that by doing a superior oblique tenotomy. The second is the alignment you get with this procedure on the table under anesthesia is the alignment you're going to see when the patient's awake. So if the patient is overly esotropic, you can adjustably recess those ends back. If still exotropic, you will see that when the patient's awake. So you can kind of count on what you see is what you get, because it's a purely mechanical procedure, as Ed has pointed out as well. It is very challenging to do in a patient who's had a large prior lateral rectus recession. not only for finding the lateral that we all know how to do, but the lateral is foreshortened. The sarcomeres are shortened. It's very hard to split it long enough down its long arm, as was discussed with this lovely presentation, to bring it safely around the globe without causing some kind of compression of the globe or some kind of problem. And my last comment is that just with 6 nerve palsy, we look to see if you have a partial 6 nerve palsy, because then maybe a recess resect is better. Not to forget, you need to make sure you don't have evidence of some medial rectus function, because if you do, it may be wise to go to your basic techniques, as Ed was talking about, taking advantage of that, and not forgetting that we have some good lifelong experience. I think the one advantage of the nasal transposition, however, for a complete third nerve is that I think it's a lasting procedure. I don't think it wears over time.
Greg?
Just a quick comment. Can you hear me okay?
Yes.
Good, good. The subject of our last EAPOS meeting a week ago was the use of titanium plates to create a platform to pull the muscle in adduction. And in our orbital center, they are working on a artificial muscle that may fill the requirements that Ed has outlined, which is elasticity and contractility, although I suspect that'll be a while.
Is that David Z who's working on that?
That's exactly right.
Yeah, to me, that's the holy grail. If we could finally come up with a material that we can substitute for the muscle that has the appropriate properties and won't get fibrotic reactions from the tissue surrounding it, making it ineffective, we will have a huge step forward.
Encapsulation of the prosthesis will be an issue, I suspect.
Absolutely, that's the problem.
I would like to add one thing. What I like about this procedure is, I mean, this was one aspect where you have to split the muscle, but you can use it, as we often see, to also correct simultaneously large hypotropias if you move the muscle superiorly, you transpose it superiorly. And I think that is a nice procedure then, because you don't have, you're addressing one muscle and you don't have to operate on the superior oblique and try to mess around with the medial rectus and the lateral rectus. That's something that I like. I don't know what your experience is there.
Yeah, it can work. Absolutely.
So one of the questions coming in from the audience is, do you ever add medial rectus plication or resection to this procedure?
When we do this procedure, we do it in a case with complete palsy. When we do this procedure, we do it on a case with complete palsy of the medial rectus. So adding any resection would not be of much use.
Are you hearing me?
Yes, I'm answering. So I don't think it's useful to add resection or anything or any to this procedure, because if you start with a functioning medial rectus, even if it has a mild
so let's go
function,
on to the next speaker. Can we have the next presentation?
You're hearing him, Sarah. He's talking. You're hearing him.
Thank you very much for having me here. We're going to talk about, we spoke about how to move the eye inward and outward. We're going to talk about how to move the eye upward or downward, depending upon the situation. Having said that, the most common type of transposition is for 6 nerve palsy. All around the world, I think that's the most common. If you look at transposition for hypotropia, you generally see it in monocular elevation deficit or superior rectus aplasia or hypoplasia. What are the options we have? We can transfer the muscle, the procedure called NAPS, or we can, what we learned from 6 nerve palsy, we can go for monorectus transposition of either medial rectus or lateral rectus, which we'll speak about in a little bit. In terms of third nerve palsy and the congenital fibrosis of extraocular muscles, when there are hypotropia, you can transpose the superior oblique. So the fun in vertical deviation is that you have the muscle that is inferior rectus and superior rectus. We can do a recess resect of that. You can take advantage of horizontal muscles, that is medial rectus and lateral rectus. We can transpose them up or down. It's called naps or inverse naps. You can take advantage of oblique muscles. This is additional thing what is available for hypo or hypertropia. we can also do augmentation and adjustable procedure. What are the options available for hypertropia? In cases of traumatic inferior rectus damage, we have inverse naps or monorectus transposition. In terms of aplasia, we also have inferior oblique nasal transposition. So whenever there is hyper, we can take advantage of inferior oblique muscle if you don't want to touch the horizontal muscles. In cases of hypotropia, you can take advantage of superior oblique. As discussed in 6-nerve palsy, we discussed for almost 35 minutes. There are multiple procedures. I'm just going to concentrate on 2 procedures for both hypo and hyper. And superior oblique especially will be spoken by my colleague, by the next speaker, Dr. Kamal. So this, when you do an APS procedure, you can transpose the muscles, either full thickness or even partial thickness if you are worried about the anterior segment. You can even put an augmentation suture. This is the classical procedure which have been taught, like what is there for 6-nerve palsy as well. What I do, or when do I do transposition? Whenever there is large hypo or hypertropia, very, very large, the eye is not moving midline. This is one of the simplest rule where we can decide. And also on the force reduction test, either the inferior rectus or superior rectus is not very, very tight. If it is really, really tight, relieving that restriction is more important. My procedure of choice of late has been similar to the 6-nerve palsy. I do the transposition of lateral rectus or medial rectus to this superior rectus in hypotropia and add the inferior rectus. This way, you can spare one of the muscles, and also 30 to 40% of monocular elevation deficit patients have horizontal deviation along with this. As you can see this in this patient, there is a ptosis, there is a large esotropia, large hypotropia. We did the inferior rectus as well as the lateral rectus transposition and medial rectus recession in this particular case, because we still had to do 3 muscles because of the young age of this patient. We could do it. You can see a very, very small the lower lid retraction after the surgery. This is one more patient. It really improves the elevation by 1 to 1.5 units in most of the patients with regards to the transposition. And why do you do? It's a single transposition, helps in taking care of horizontal deviation in 30 to 40% of the cases, and less chance of anterior segment ischemia. This is one of the publication we did, either of the horizontal muscle, medial or lateral rectus, along with inferior rectus. We had a good outcome in these patients, and it achieves the adequate elevation effect and the primary position deviation correction, at least in the short follow-up. Coming to the next topic, when you have hypertropia, most commonly we see in inferior rectus aplasia. As you can see in this CT scan picture here, the inferior rectus is absent. We can do inverse naps. Also, we can do partial inverse nap. We can also follow this medial rectus or lateral rectus transposition, or inferior oblique anterior nasal transposition with or without resection. When it is with resection, it's called a ratio surgery. This is one of the patients who had vertical rectus transposition, unfortunately developed a huge right hypertropia. When we looked at the inferior rectus, we could not really see it. What we simply did is we did a nasal transposition of the inferior oblique, and you can see it corrected, but you can see that the depression is still limited. This is where the option of other muscles also comes into play. So it gives a moderate improvement in the depression. This is the pre and post-operative picture of the same. I would end with this video of 2 patients of aplasia. You can see a very large hypertrophy in this patient on the left side, and the first patient on the right side. What we did is the inferior oblique nasal transposition. How do you really decide about nasal? It's just that you can measure from the limbus and imagine the position of the inferior rectus and put this inferior oblique nasal to that. And some of us really propose doing a resection, a small bit of resection of inferior oblique. That's called ratio surgery. Along with, we added a superior rectus recession. You can see the pre and post-operative improvement in this hypertrophy in these two patients of hypoaplasia of inferior rectus. This is on the right side, and the next patient is on the left side. In summary, I would say that medial rectus transposition or lateral rectus transposition with inferior rectus recession works good for hypertropia. And whenever you have hypertropia because of these things, obviously it depends on, very similar to six-nerve palsy. If the patient has a very huge esotropia with the large abduction limitation, probably we'll have to go for the naps. But in moderate cases, this really works well with a good surgical outcome. Thank you very much for this opportunity. I would like the discussant to give their comments on this case. Thank you very much.
Ramesh, I just have one question. I think it's a great presentation, and certainly your results were impressive. You showed this one patient that had an esotropia and a hypotropia. And yes, why didn't you use the medial rectus to transpose it superiorly?
Yeah, the thing is that we were at the initial stage of that cases. Like if you don't have this procedure, earlier we used to do that. When you recess the medial rectus and transpose, the effect, what it gives is much less than when you directly transpose that muscle. That is the idea behind transposing the lateral rectus in that particular case rather than on the medial rectus. Probably the medial rectus is a much stronger muscle, probably, but in that particular, you will have to get the correction of that 25 to 30 prism diopters of esotropia. For that, you have two options, either to do the medial rectus on the same eye or go to the other eye. These two options. That's why I chose lateral rectus in that particular case.
Yeah, so very nice presentation. This gets back down to David's question about what is success. And you know, I think what you showed us is that using the technique, you can get the eyes pretty well straight in the straight ahead position. But I didn't see any of them that had full duction on down gaze. And to me, that is one of the measures of success in these vertical deviations is not just straight ahead, but down gaze, which usually means that something has to be done to the other eye. You really can't solve these problems completely with the involved eye. You need to do something on the other eye. And I would opine that in most of the cases that you showed that a inferior rectus Faden operation would probably do the trick and get them close to single, if not single on down gaze. But, you know, in my hands, I've not done an isolated lateral or medial for correction of a vertical. Most of the time it's either recess, resect, or a full tendon transposition of the lateral and medial in the direction that you want to go. And the point you made was is a very good one, and that is most of these oftentimes will have a tight opposing muscle, and if you don't recognize that, you're going to fail in a transposition. You're going to have to do something about that tight inferior rectus or superior rectus, depending on which muscle is involved. But it usually takes something on the other eye in order to make this work.
Yeah, I agree with that comment. That's why I ended with the comment that even in sixth nerve palsy, all patients, the monorectus transposition does not work. In our experience, I think in 30 to 35% of the patients, it does not work. If somebody has a lost inferior rectus with the deviation in the primary position, maybe up to 70 or 80 prisms, the eye is not even coming to the midline. Maybe it's just there. I think we need to do a full transposition, or as you said, we have to go to the other eye. So I just shared two of the techniques which can work in most of the cases. I left rest of the part for discussion so that because we can discuss for one transposition for almost an hour, but these techniques can be utilized in appropriate cases, but that's not the only procedure which can work in 100% of the cases. That's completely agreed.
So Ramesh, I would like to ask you something. If you have a large horizontal deviation with the vertical deviation as well, would you do the horizontal muscles in the other eye? Would that be something also that you would use the other eye for?
Yeah, it can be done. If it again depends upon the amount of deviation what we have. Most of them can be tackled with one horizontal muscle. Most of the patient, not all, most of the patient we can handle with one muscle. So in that case, either you can go to the other eye or you can do it in the same eye. For example, if the patient has just hypotropia with the very small esotropia of maybe 18 or 15, we can just do it in that eye and you don't have to go to the other eye. If the same patient, we do have patients with hypotropia with 50 to 60 prism diopters of esotropia, we have to go to the other eye. So I mean, you might be touching the third muscle in some of the cases. That's what you meant, I guess, when you said when you have a horizontal muscle, you have that.
Yes.
We earlier we used to have, if a patient who is to come to us, if the patient has 40 or 45 prism diopters of esotropia, we do this recession and transpose. They don't give a very, very good outcome in terms of vertical deviation. We had that challenge because we see a lot of patients with horizontal deviation in monocular elevation deficit. Here, it gives an additional advantage of one more muscle. And always the top question, how many of the patients has torsion? This is there. None of the patients developed symptomatic torsion, and is especially useful in monocular elevation deficit patients. Most of them are suppressed. But if they have an inferior rectus trauma patient, they may be fusing patients. So we did not have so far any kind of torsion. Maybe the number is too less to talk about the torsion, but it's very negligible.
I think
any
it's probably,
person on the
it's probably time to go to our next conversation.
Okay.
I mean, strabismus
So
often does feel like a chess match where you have to think multiple moves ahead. And that kind of thinking is valuable. And sometimes you're down to your last piece. Ahmed, what do you do? Oh, Craig, you're going. I'm sorry.
No, I apologize.
Okay, so
I misunderstood.
it's
I thought
fine.
you were
So
telling me
it's
to
actually
start.
Ahmed.
Pardon me.
It's Ahmed Mustafa Kamal who's going to talk about superior oblique transpositions. Go ahead.
Ahmed, can you please unmute?
Can you unmute? Ahmed, can you unmute?
Yes, second, just a second. Okay. My screen is okay? Now it's okay, yeah?
Not the full, yes.
Okay. The superior oblique muscle is inserted in the upper posterolateral quadrant of the eyeball. The main action is depression, intorsion with some abduction. If the muscle transposes anteriorly, the main action will be intorsion with some depression. If the muscle inserted anterior to the insertion of superior rectus, the main action will be adduction and elevation. If the muscle inserted at the insertion of the medial rectus, the action will be increased adduction and increased elevation. The anterior fiber of the superior oblique are responsible for torsion, and posterior fiber are responsible for depression. So selective surgery on anterior or posterior fibers may be an option in certain conditions. The common example is harada ito, in which the anterior fiber are inserted 8 millimeters posterior to the upper wall of the lateral rectus. So Superior oblique is intorsion, but can be have minimal intorsion. It is depressor, but can be elevator. It is abductor, but can be adductor. Case number 1. This girl is 5 years old. The parent complains of drooping of the right eyelid at the age of 1 year. The vision in the right eye 660, in the left eye 66. At the right suppression, poor pelvis phenomena, the fundus showing right intorsion. The ocular modality, the angle of deviation in the primary position showing right esotropia, 35 prism diopter, and right hypotropia, 30 prism diopter. The ocular motility in different direction of gazes showing the patient has marked limitation of right abduction, minimal limitation of right adduction, and no elevation at all of the right eye. Let us zoom on different gazes. It is the right gaze, marked limitation of right abduction, minimal limitation of right adduction, no elevation at all of the right eye in different position of gaze. In down gaze, she has limitation in down gaze to the right, but otherwise the down straight and down to the left is okay. So our diagnosis is right third nerve palsy with incomplete recovery of the medial rectus with right sixth nerve palsy. So the remaining functioning muscle of the right eye is the right superior oblique with minimal function of the right medial rectus. What is the aim of our surgery? Our aim to improve the primary position of the patient. So the force reduction test done in the OR and found of the right eye that was negative, no tight muscle at all. So the decision was right superior oblique transposition with right medial rectus resection, 7 millimeter, right lateral rectus resection, 10 millimeter. The superior oblique transposition in this case, we didn't insert very far anterior from the insertion of superior rectus because we need the elevation, yes, but in this case with sixth nerve palsy, we don't like the adduction of the superior oblique. So we just inserted at the medial side, the medial pool of the insertion of the superior rectus. The immediate first week post-op showing improvement in the right of the primary position, pre-op and post-op. The late post-op showing cosmetically very acceptable and satisfactory result for us and for the parents. Of course, we didn't expect any improvement in different direction of gaze. Our aim was just to improve the cosmetic appearance in the primary position. In case number 2, this patient is 20 years old, history of squint and lethargy of the left eye, has a leftosis, left mid-dilated fixed pupil, has a left XT 75 prism diopter, the visual acuity is 20/50 in the left eye, with limited ocular motility in all direction of gaze of the left eye except the abduction. Is a typical appearance of complete left third nerve palsy. In the OR, we found that the left lateral rectus was tight and it was recessed about 12 millimeter with scarring of the left medial rectus. So most probably the procedure done outside our hospital in the left eye, it was recess resect of the left eye with no improvement. So the decision was fixation of the lateral rectus to the lateral orbital wall with superior oblique transposition to the medial rectus. The first day post-operative, it's satisfied result. And 1 week post-operative still is cosmetically is very good in the primary position. Our last case, this child has a history of fall from height and MRI showing the superior rectus is severed. Exploration of the superior rectus intraoperatively, we didn't find any trace of superior rectus at all. So the decision was to superior oblique resection with insertion at the site of the insertion of the left superior rectus muscle. Post-operatively, marked improvement in the primary position. It's our aim that just the primary position. Our take-home message for these cases, the superior oblique may be the last option when there are no other options. Superior oblique transposition without horizontal muscle surgery has a limited effect. The aim of superior oblique transposition to be elevator and adductor. Thank you.
Okay, can you stop sharing your screen? Thank you. Dr. Edward Buckley. could you please tell us what you think? I'm sure you have a lot to say.
Yeah, first of all, very nice talk on trying to incorporate the superior oblique. This gets into how is the superior oblique innervated and what are we doing with it? I had the unpleasant experience very early on in my career of taking the superior oblique out of the trochlea, putting it into the medial rectus to try to help pull the eye in. And it did. It looked great in a straight ahead position until the patient started to look down. And what happened was the superior oblique is innervated when you look down. And so the eye went into a deduction because that's where it was located at that point in time. So any of these cases, what you really want to look at, if you're trying to go for something more than just straight in the straight ahead position, it's not gonna work. And what it's going to do is it's going to give you a funny aberrant innervation movement as you start pulling the eye around. And so that's the downside of it, is that if you were to take a picture of that individual looking over down, you'd see the medial rectus start to pull in. So if you have somebody who can fuse, none of these patients were really fusing patients, but if you're trying to use this in a patient who fuses, it's fraught with all kinds of trouble because of the aberrancy of the innervation movement that happens when you relocate the superior oblique out of its normal position into some abnormal position. So I kind of avoid that situation most of the time.
Would you have done something else for the last case?
Well, I mean, the last case.
Mm-hmm.
Yeah, I mean, the last case is stuck down, right? So basically, you're going to need to if you all you're trying to do is get the eye straight, you can recess the inferior rectus. That'll get it up. You could recess the inferior rectus and move one of the horizontals up, or split the horizontals, move them up, and recess the inferior rectus. You're going to have to do something to the inferior rectus to get the eye into a reasonable position because it's obviously way tight. But you would take out that innervational issue of having the superior oblique in a funny position. Just beware, especially if you got a fusing person, of moving the superior oblique around.
Daniel?
I think that's exactly what I wanted to ask and to get at, because the inferior rectus, of course, is a powerful depressor, but it is a pretty strong ex-cyclorotator. And if you then knock out the superior oblique, which is pretty much the only in-cyclorotator at that point, because your superior rectus is gone, I would think you would end up with a very, very large ex-cyclorotation. I mean, even if you recess the inferior rectus. So I would be wondering if that was the case, if there was maybe, I mean, in a child may be difficult, but if there was fundus extorsion postoperatively or something along the lines.
And Ahmed, can I just ask you, when you transpose the superior oblique, do you resect it? And if you do, how do you titrate that?
Actually, in normal condition, no, but the last case, yes. Normal condition, just recession of the the superior oblique without any resection. But in the last case, we need maximum elevation because of the last superior rectus. Just we do resection of superior rectus, superior oblique, till we find it's tight to be able to elevate the globe up.
Any of the other panelists would like to share their opinions? Okay, so we'll move along. And Dr. Craig, would you please share your slides with us? Thank you.
Should be up now. Is it? Ah. There, okay. Do you see this okay at this point?
Yes.
Can you, good, perfect. Yeah. Dr. Ahmed, I apologize for leaping in front of you there. I misunderstood.
No problem.
And I want to thank both organizations for this very kind invitation. It's nice to be back in Egypt, even virtually. I have no financial interest in any of this. The anterior segment ischemia is, of course, quite rare because we're all very good at avoiding it, but it does occur, and this is a human patient 1 day post-op with folds. And then we'll from time to time see the sequelae. This is a patient who is a different patient that has iris atrophy, immobile iris also in certain segments, a segmental cataract, and these can be severe enough to go on to form ptysis. Well, risk factors for anterior segment ischemia are many, but age and the total number of rectus muscles receiving surgery are by far the most important risk factors. Staging the surgery may help some with collateral flow, but there's some work by Jane Oliver many years ago showing that the anterior ciliary vessels generally do not recanalize. Now, there are circumstances, which we've seen today, where the ideal procedure from a purely mechanical perspective may create a significant risk of anterior segment ischemia. And an example would be a 60-year-old with a large angle esotropia from a 6th nerve palsy that received a recess resect procedure that didn't work well and now requires some type of transposition, of which, as we can see, there are many. Let's look at anatomy. And this is fortuitous for the surgeon. The anterior ciliary vessels travel in the substance of the muscle until just before the muscle transitions from muscle to tendon, and then they emerge and travel on the surface and continue where the yellow arrows here are onto the surface of the sclera to either penetrate into the rich anastomotic network of the anterior circle of the iris, or to travel over and communicate or connect to neighboring anterior ciliary vessels. So this creates a nice potential dissection plane. And you'll notice in this group of vessels, there's one arterial-like vessel in the center, but several venous-like vessels. So we always use the operating microscope when we do this, a standard instrument set, and then a couple added instruments, a modified Jamison hook at the top, some microvascular forceps that we borrowed from the neurosurgeons, a Sinskey hook or some type of retinal hook works very well for lifting the vessels. And I used to use these wonderful Grieshaber scissors shown here, but now I use whatever disposable Grieshaber scissors or equivalent brand happen to be available. The dissection technique is really quite straightforward. We use the angle scissors here to create a dissection plane, lifting the vessel. We try never to touch the vessel with these microvascular forceps. There are not very many branch vessels feeding the tendon, since it has probably very low metabolic needs, but they are encountered occasionally, and we will do bipolar cautery as far away from the main trunk as we can to try to avoid back thrombosis. And the placement of the suture in the tendon after dissection is really quite straightforward, as you'll see in a minute. And this is a partially completed tenotomy with our vicryl suture in place and 3 groups of preserved anterior ciliary vessels that we hope are also functioning. And this is what a cartoon of a full tendon transposition would look like. We've also done recessions and resections. And this is the cartoon on your left of the muscle on your right. And where my arrow is, you can see the anterior ciliary vessels running back to the original insertion site. And of course, the question is, do they function? And that we used a variety of studies, which I will not go through today, using iris fluorescein angiography. This is about a 3-minute video. I'm going to show a small portion. Notice there are 4 groups of vessels that look like significant conduits from the muscle to the sclera. This one pulsates. We're taking the vitreoretinal scissors here. Notice we're never grabbing the vessels directly, creating a dissection plane, which again is in a layer contiguous with the muscle capsule. And then we go forward and backwards. And a lot of the dissection can be done bluntly. Be careful cutting as we are here, both anterior and posterior, but at times you have to do that to sort of strip the capsule. But a very nice way to do much of it will be with forceps and a lifting device. So using the hook, you can see just by blunt dissection, the vessels are generally stronger than the supporting tissue, and you can use traction and counter traction with or without cutting and move forward and backwards. The 2 critical points are, as we get to the insertion, which I'll show you in a moment, here you have to be quite careful cutting, and as we begin in a moment to make a cut posteriorly, this is also where you can get into trouble. I also think it's a bad idea to use this rough general surgery style suture, it's better to do a cyclodialysis spatula to lift them. But notice there are 4 groups of vessels here that have been dissected and preserved on an inferior rectus. And in a moment, we'll pass the suture. I use a S29 needle on a 6.0 vicryl. It's easy to pass it under the microscope, and you just simply comb the preserved vessels to the side. Our second-year residents have done this with me. So it's a bit tedious, but certainly very doable. And here we're cutting the tendon. Sharp Westcots are being used, trying to get the anterior blade just behind the vessels we've worked hard to preserve. And you have to be a bit careful as you get to the end of the tendon, because it will abruptly snap back and the hook may snap forward, and you'll see that abrupt snap back here. So the trick is ease up a little on the hook as you cut the last few fibers. There. Now, the muscle is back probably about 10 millimeters. The vessel over here flows so fast you can't see it fill, but this one, notice, fills from front to back. The other one probably fills back to front, but way too quick to see. In the final few seconds here, we'll pass this S29 needle again, which is a thin wire diameter, third of a circle, in a very standard fashion. I believe I'm 4 or 5 millimeters behind the real insertion there. And then we pull the muscle forward. And again, trusting that the vessels work. We inadvertently recognize destruction of about 10%. Now, does it work? Well, my fellow in Boston scoured the country and obtained 4, and I must say elderly cynomolgus monkeys for an animal model. And the picture on your left, we thought we would need a slit lamp and fluoresceins to see the ischemia. Not so. With the elderly monkeys, we did a recession on all 4 muscles on the control eye without preservation of the anterior ciliary vessels. And to a monkey, all 4 looked exactly like this. The right-hand picture shows the same procedure, but with preservation of the anterior ciliary vessels, and all 4 eyes on the total of 4 monkeys looked like the one on the right, indicating that if you're operating on elderly monkeys, at least the cynomolgus ones, this procedure works, and we think so on humans. Now, as so often happens, we thought we were being quite original, but it turns out in the European literature the very same year by Dr. Roth, something was published similar. And in another reference by Carlson, referring to Dr. Jampolsky, moving the anterior ciliaries to the side many years ago. And this is just one of a number of plication techniques, that can be used. And this is from Ken Wright. Thank you very much for inviting me, and it was a pleasure to participate.
Thank you very much. It was a great video.
I hope it came through good.
Dr. Buckley, yes,
yeah,
excellent. Dr. Buckley, is that your to-go-to procedure for avoiding anterior segment ischemia, or do you use something else?
No, I'm not as good a surgeon as Craig is, that's for sure. So, it takes some really elegant surgery under the scope in order to free up those vessels, as you saw. And so what I usually do is try to preserve one of the vessels in the muscle and then move the rest of the muscle. Especially for transposition type procedures, I end up converting to a Humbolsheim, where you're leaving I take as much muscle as I can get, but leave one of the vessels there. I noticed, Craig, that when you do this transposition, you use a nap type procedure as opposed to a parallel to the spiral. Is that what I was seeing?
Actually, I used 3 different positions depending on how powerful I want it. One mimicking what Dr. Jampolsky and Art Rosenbaum did years ago. Follow also the way Marshall Parks taught me, which is splitting the tendon, and also in this instance following the spiral to low. For this diagram, that's what it was, but that's not always the way I do it. No one has done the proper study to determine which of these techniques is most powerful, of course, for placement positions.
I guess the reason I was asking was that in your cartoon, it looked like there was a significant advantage with traction on the vessels by putting the muscle perpendicular to the, putting the transposed muscle perpendicular to the muscle you're trying to augment, as opposed to putting it parallel. Less stretch on the vessels that you're leaving behind, I guess, was what I was noticing.
Yes, Ed, that's probably true, although generally these vessels travel in such a serpentine way that there's plenty of slack. But that would certainly if it appeared they were under too much tension, then we would move it back. And then when we started doing this, we were doing postoperative fluoresceins on as many patients as we could, and it appeared that it was not disturbed. But there are a few vessels that thrombose after surgery that we think are intact. We don't know what that number is, probably about 10%.
And so the question begs itself, so you're down there separating this out, and then all of a sudden there's an oops moment, and you ended up sacrificing the vessel. How often, in my experience, the risk of anterior segment ischemia, even though we think we always worry about it, is really, 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 really low. And the risk of really causing permanent damage, other than maybe a cataract, is probably zero. And so what happens when you lose these vessels, or is that something you've gotten so good at now you never do?
Well, if we lose them on the first muscle we're going to transpose, then the critical decision is, do we go ahead to the next muscle? But fortunately, in general, there are 2 arteries, so we have never lost all of them on one muscle.
Gotcha.
So
sorry.
Daniel?
Beautiful video, thank you. A couple of years back, I switched from resecting procedures primarily to folding procedures. I have never done any formal studies, but I wonder, because when you really you do a 6 millimeter plication or 8 millimeter plication, you are really folding and singeing these vessels, even though you don't disrupt them. But I wonder if they stay patent. Have you looked at that?
I have not done plications, but I am quite convinced that our preserved vessels stay patent. I've done no studies on the few plications I've done where I've tried to spare them. But I would agree, it's something that should be probably studied. We were hoping to be able to do OCTAs on the anterior ciliary vessels. Thus far, we have not been very successful. And we would need direction of flow, of course, or should have. But that's going to be possible.
Daniel, in the work we reported, we did show that there was maintained blood flow, and so did Ken Wright with application. So that is possible. Craig, I was curious, I use iris angiogram pre-op as part of my planning, and somebody who's had more than one operation, so I know where I am and what's going on. If there truly is one muscle left that still has blood flow, although my experience is mimicked Ed's, that anterior segment ischemia is very, very uncommon. Still, if there's one muscle left and it's the blood flow muscle, I try and avoid it and go somewhere else. Does anyone else do that, Craig? Do you do that?
When we initially started doing this, we tried to do pre and post-operative angiograms on all of the patients. Now, fluorescein angiography is becoming a lost art among our photographers, and very few of them know how to do iris fluorescein angiograms, and it's a bit more challenging, although there are ways you can do it with brown irides. So hopefully we'll have another technique. And I agree with all of you that anterior segment ischemia is extraordinarily rare, which is why we were very interested in that monkey study. What I didn't know is that elderly monkeys really are susceptible, but young monkeys aren't. Which is like humans, at least cynomolgus monkeys.
Linda, yes, please.
I have two questions that, Craig, maybe you have the answer to. One often comes up, and I don't personally have experience as you do working into the microscope doing this particular type of vessel sparing. Do you have a sense of a length of time between procedures if you're trying to avoid anterior segment ischemia that you suggest patients wait? And also another issue, there's plenty of reports in the literature of aggressive conjunctival dissection increasing the risk. And for your patients, where are you making those conjunctival incisions? What are you doing something else
based
special?
On the studies that David Guyton had done years ago on this same animal model we used, we try to use a fornix incision to avoid disturbing the limbal circulation, unless the conjunctiva for some reason is too thin on a very elderly patient, in which case sometimes the vessels become rather fragile too. The thing I have learned is don't book 2 of these on the same day. We generally allot a half hour per muscle, but I do this with the second-year residents, so typically they will do one and I will do one. So it can be done.
Thank you, Craig. So we'll move to the last speaker, Ahmed. So Ahmed Awadin will present under and over corrections after muscle transposition.
Can you see my screen?
Yes, we do.
So the two main variables that the surgeon can control during muscle transposition are the technique of the muscle transposition and the amount of weakening of the antagonist muscle is performed. The greatest surgical response to muscle transposition is achieved when a full tendon transposition is combined with an augmentation suture or with resection. Note that you can also modify the amount of resection or the position of the augmentation suture in order to tune the surgical response. The other modifiable variable is the amount of weakening of the antagonist muscle and whether a botulinum toxin was injected or not. This can be fine-tuned by using an adjustable suture or even staging the procedure. However, one should note that if you're using an adjustable suture, there will be a small post-operative drift in the first 2 months after surgery. The amount of drift is greater with a partial tendon transposition than with a full tendon transposition. So this patient, for example, presented with a right 6 nerve palsy. She had a right Janssen procedure. On the first day after surgery, she had an excellent alignment. But you can see that 1 month after surgery, there was a small isotropic drift. Now, this is another patient with a right 6 nerve palsy. Again, she had a right Janssen procedure. On the first day after surgery, she had a small overcorrection. And you can note that 1 month later, this overcorrection disappeared. But nevertheless, how hard we try, I will always get some undercorrection. Whenever you have an undercorrection, a force reduction test should be done to detect any residual tightness of the antagonist muscle. This patient, for example, presented with a right 6 nerve palsy, and because the angle in the primary position was minimal, I opted to do only a right Janssen with no medial rectus recession. But because the medial rectus was still tight, I got a marked undercorrection after surgery. So I had to go back and do a medial rectus recession to relieve this tightness and improve the alignment in the primary position. The problem is that when the antagonist muscle is not tight, then the options are a bit limited. The management will depend on the angle in the primary position and whether the eye can cross the midline or not. If the angle is small and the eye can cross the midline, one can do, as Dr. Edward Buckley mentioned, an innervational eye muscle surgery. This beautiful baby, for example, presented with a left 6 nerve palsy. He had a left Janssen procedure and following surgery had only a very small undercorrection, and you can notice that the eye can now cross the midline. In such cases, one can do either a posterior fixation suture or a combined recession resection to the yoke muscle, that is the right medial rectus, in order to improve the alignment in the primary position and to reduce the incontinence. In some cases, however, the angle is too large to be corrected by a single surgery. This patient presented by diplopia following an endoscopic sinus surgery and an injury to the medial rectus muscle. Presented with a very huge exotropia and a marked limitation of adduction. In this patient, I opted to start first with a full tendon transposition with vessel sparing. Because the angle was large, I also combined this with a dual augmentation using an augmentation suture and also by resecting the superior and inferior rectus muscles. But because the angle was a bit large, I ended up with a marked undercorrection. So I had to go back and do a right lateral rectus recession, which was not performed in the first surgery. But again, the response was not that great. So finally, I had to go a third time in order to do a nasal transposition of a split lateral rectus just to improve the alignment in the primary position. While undercorrection is far more common than overcorrection, overcorrection still does occur. The difference between overcorrection and undercorrection, in my mind, that overcorrection would need timely management. In order to better illustrate this, I would show you 2 cases. The first patient presented with a left 6 nerve palsy and a -5 limitation of abduction. He had a full tendon transposition with augmentation sutures and no medial rectus recession. Unfortunately, after surgery, he presented with a large overcorrection. Two, you opted to wait for 3 months in order for this overcorrection to improve, but it did not. So finally, we had to go 4 months after surgery in order to cut the augmentation suture and to put the transposed muscle back to the original position. But there was little or no improvement with persistence of the overcorrection. Now here is another patient. She presented with a right fixed nerve palsy, a -4 abduction deficit. This patient, she had a Janssen with clear augmentation suture and a small medial rectus recession. This patient also ended up with a large overcorrection in the second day after surgery and a terrible diplopia. So the difference is that in this patient, we did not wait that long. We just went 1 week later, we just took off the augmentation suture and put the transposed muscle back to the original position. And 3 weeks after surgery, there was an improvement of the overcorrection with only a very minimal tiny undercorrection. So whenever you have overcorrection, one should consider early intervention because probably these changes might be very hard to correct later on. I would argue also that these changes would apply, the same principle would apply to vertical deviation. Whenever you have a vertical problem or imbalance after transposition, one should interfere early because late correction of these vertical problems might be very difficult. Thank you.
Yeah. So very nice discussion on, on what can potentially happen in these kind of situations. The first caveat is that most of the times when you get an overcorrection, if it's not too bad, then it's actually easier. You get a better long-term result because you now have the paralytic muscle or the palsied muscle is now moving better. And so usually it's a pretty good ability to work around that particular issue and you end up with a really good result. So I don't worry too much about overcorrections unless they're really stuck in one position like your big XT, and then obviously that's a problem. But I think in any of these kinds of procedures that we've been talking about today, you always have to think about what the plan B is and try not to create a situation which is very difficult to modify going forward. I tell residents and fellows, the patient comes in with a problem and it's their problem until you operate on them, and then it becomes your problem. So if you don't have a way to fix that problem, then you're going to get yourself into a lot of trouble and angst, both because of the outcome and because the patient is not happy going forward. So I'm always thinking about the next step. If what I did doesn't work, what's the next procedure that we can do to try to get us where we want to go? And clearly sometimes I've always been amazed when, one of the things you said was taking down the transposition. So you start out with a -4 abduction deficit, you end up with an XT, you take it all down and it works. What happened there? I haven't a clue how, why that works sometimes, but I've had that same experience in simple ETs and XTs where you end up reversing the procedure, putting everything back where it came from, and you've cured the strabismus. So you always have that phenomena that goes on, but nice presentation.
Yeah, go ahead, Ahmed.
Now you're just asking him, whenever you're doing a surgery with the yoke muscle, you do more of a faden or a combined recession resection?
Yeah, well, a combined recession, I think, is one which will work. But I like the faden, just a straightforward faden on the medial and the inferior. I think it works fine, and you don't get yourself into any trouble doing that. For the lateral and the superior, the arc of contact is so far back that getting a good suture placement is really difficult. And in the lateral, you're back there by the macula and the inferior oblique. So for the lateral, I really love the resect recess procedure. I think it works really well. And in one of your patients there where you had a big XT over on the other side, again, going to the other eye and doing a big recess resect on that lateral will get rid of that XT on side gaze. We haven't talked too much about that, but a lot of these transposition procedures that we do with recessions, etc., end up creating a problem in a gaze where they were straight to start with. And that problem for most of these ET types is an XT. And so you have to keep that in mind when you're planning your surgery, that you might create a problem in the only place that the patient was actually seeing single to begin with. And think about how you might modify or develop a plan to address that if it comes up.
So just a question for you too, again, Dr. Buckley, please. How long do you wait if you have a really unexpected large overcorrection after a transposition procedure?
I think it depends on deductions. If you have a big overcorrection, but the eye is moving really well, then I will wait because it tends to regress to where it came from, and so you have to be careful of that one. If the eye's not moving well at all, in other words, you've got a significant restriction, that's probably not going to go away. For whatever reason, you've just got more effect, or the tissue is doing things differently than you expected, and then I think that one's a sooner rather than later. One of the things we hadn't talked about was when we do these transposition procedures, sometimes you create an unwanted, especially for horizontal deviations, you create an unwanted vertical. How long to wait before that? And the conventional wisdom on that is you better go back pretty quickly, because that's probably not going to go away. And if you have a fusing adult, especially, which is what we have in most of these situations, you're going to need to do something. And it's usually better to adjust the transposition before it all sucks in, as opposed to waiting for 6 to 8 weeks and then having to go back in. And as already been alluded to, it's not an easy operation second time around, no matter how good of a surgeon you are.
Thank you. Daniel?
I think if I may just add this, because it came to my mind, we do know a lot about strabismus, but we by far don't know everything. And this is similar to the maybe intermittent exotropia, where in 95 to 98% of the cases, we get a recurrent exotropia. But in very few cases, we get this persistent overcorrection, consecutive esotropia, as you showed in these informative cases. And I don't know what the answer is, but wouldn't it be nice if we were able to tell these apart? I don't know how to, but there must be something that distinguishes these cases. And if we could find that answer, I think we'd be better off, and our patients would be much better off, because these are the cases that, even though they are very rare, they take a lot of your time, and these patients are really, really unhappy. So I don't know what it is. I hope that we'll find, maybe together we'll find what these factors are that distinguishes these patients.
So you've raised the third of the three major issues that I wanted to make sure we talked about today. And one was, like, what are we actually doing? And that was whether it's the cranial nerve or creating a spring. What is success? And have we set patient expectations properly? So, I mean, those are the three big things that we have to deal with when we deal with transpositions, to understand what we're getting. Otherwise, we fall down a little bit in what we're doing. Linda, you had a comment?
Yeah, I had a question for Ahmed and Ed Buckley, since you had a lot of experience with the recess resect versus Paeden. Clearly, either of those two can be very helpful if you're trying to create some kind of competence for your patient. But for patients who are diplopic, do you or any members of the panel have a sense of a preferential choice? If you think about a Paeden, for example, for a patient who has a blowout fracture and you have problems with the inferior rectus, you go to the contralateral eye, you do a Paeden procedure. The reality is that as the patient goes into downgaze, there's a region of diplopia until that Paeden effect is reached. It's not like all along there's that limitation. And do you have a sense of whether recess resect works better for that mismatch or a Paeden, and based on muscle or based on your own experience?
Well, I don't have a huge experience with combined recession resection. I tend more to do a Paeden. I like Paeden. I think it works better. My problem with combined recession resection in the few cases I operated on is that I don't have a specific algorithm how much to recess and how much to resect. And even if we did it using an adjustable suture, I'm still not confident enough of my surgical table. But I think if we did more cases, we can probably get the same result as a Paeden.
Yeah, Linda, I haven't noticed any difference between the two for really. And remember, the FODN basically just changes the arc of contact pull point. And it starts right away. I mean, you're now not pulling from the insertion. You're now pulling from someplace 10, 12 millimeters behind the insertion. And so it has an immediate effect, and that effect travels until you end up at the end of the line. And oftentimes, the double vision really doesn't occur until you're in extreme gaze with that muscle. So if you have somebody who has a problem on down gaze, and you're doing inferior rectus FODN on the other eye, they do pretty well for 10, 15, 20 degrees, and then bam, that muscle, the involved muscle stops, and your FODN didn't stop at the same place. It keeps going, and you have double vision on extreme gaze. So I have not seen any difference between
those two
operations.
So I have a question for the entire panelists. Is there a lower age limit for doing transposition surgery? Because especially for Duane syndrome, because I did operate on a case that ended up with a large overcorrection. So I'm wondering if there is maybe a lower age limit for these procedures. Does anybody?
Actually, you know, Stacy Pinellas and Federico Velez put out a paper looking at risks for overcorrection for Duane's ET. I don't remember the year of it, but they did say operation under age 2. So I think that one of the issues is we're depending upon their binocular fusion. That's why they have that great head posture. And it could be that when they're young, their fusion is a little more tenuous. And if you get a little overcorrection, they just don't bother to hold it for you. And then you might lose the gain you thought you had. It could also be that with a smaller eye, the amount you perhaps recess the medial has, you know, sort of more bang for your buck because it's a smaller eye, and maybe you've done more than you might have had. You've had the impact is greater than if the eye was larger.
Yeah, I'm a little hesitant to operate on a Duane's really young if I can avoid it, just for the reasons that Linda's talking about. I think the longer they have the opportunity to develop binocular function, the better your long-term result will be. The only time I intervene real early is when they clearly are esotropic and they're not fusing anyway, and then tend not to necessarily go straight to the transposition. Sometimes bimedial rectus recessions will buy you a fairly larger range of single vision with a little bit of a head turn, and you can buy some time that way as well.
Okay. Any other comments or remarks from the panelists?
I don't think there is a lower age limit, but I would like to add that if you do, for example, something like the Y splitting of the lateral rectus that we have talked about earlier, should keep in mind that everything is much tighter and tenon is much stronger in these very young children. And so if you do it in an infant or in a young child, the dissection it has to be quite a bit more extensive, and you get more post-op swelling and edema than you would expect it in an adult eye, where the orbit is bigger, and there's just more space.
Greg, you want to add something?
The only thing I was going to mention is for our adults who have a field of single binocular vision, I think Ed Buckley uses this same thing, a little freehand drawing of the field of single binocular vision. Do you still do that, Ed? Where you contract where they see. I love it. Yeah, not too many people do, but we can talk to you about it. It's helpful on the charts.
Thank you. Thank you very much. It was a great discussion, great topics. And again, thank you the World Society of Pediatric Ophthalmology and Strabismus for holding this meeting with us. Really appreciate that. Appreciate your presence and time. Thank you. David, you want to end that? And
Paolo, I just wanted to, on behalf of the World Society, thank the Egyptian Association of Pediatric Ophthalmology and Strabismus for being such gracious and generous hosts. Thank you so much for inviting us and including us. And to all our panelists, thank you for teaching and sharing your knowledge. It is what we're all about within pediatric ophthalmology. Craig, I laughed when you're like, I have no financial interest in anything. That's us. That's pediatric ophthalmology. So, you know, we freely share our information and knowledge because we're just trying to help people. And it was a real pleasure to share that today with the Egyptian Association. So thank you so much for having us.
Thank you.
And thanks to all the panelists.
Ahmed, do you want to say something?
I just want to tell the audience that we're going to collect the questions as usual and send them the answers once we have them from all the panels.
Very good.
Thank you.
Thank you.
Thank you all.
Thank you all.
Bye-bye.
Bye.
Bye-bye. Thank you.